Thank you for joining this presentation where I'm going to discuss using proteomics and multiplex immunofluorescence in the setting of melanoma immunotherapy. These are my disclosures. So melanoma is not the most common of skin cancers, but it is one of the most aggressive types of skin cancer, and it does occur globally. So this is a type of cancer that has a global presence, although the types of melanoma may vary geographically. And it's clearly, in terms of clinical management, a multidisciplinary approach. It takes a team of people because the way we treat melanoma, both from a surgical and systemic therapy standpoint, are evolving. Um, and the reason there's a lot of excitement in this field, I think, is distilled down into this graph. On the left-hand side, you can see, or sorry, on the right-hand side, you can see targeted therapy. These are molecularly targeted therapies such as BRAF V600E targeted therapy, which we use in melanoma. And in selected patients, they can have an incredible improvement in progression-free survival. You shift the curve over. However, as you see at the bottom, the vast majority of those patients recur of their disease. Whereas on the left side with immunotherapy, and this is speaking about a variety of types, but the enthusiasm have grown with immune checkpoint inhibitors, you see this tail on the curve that a subset of patients have long-term durable control. And this has really been a game changer in terms of the treatment of metastatic melanoma. And you can see here, comparing on the left, historic overall survival, which was fairly abysmal for stage 4 disease, with the introduction of these newer, more successful systemic therapies, you can see that we've really improved upon these survival numbers. And this led to the Nobel Prize being awarded in 2018 for these newer immune checkpoint inhibitors or for immune checkpoint blockade. And so this is the modern era. This is from the Checkmate 067 trial. And you can see here this tail on the curve. This is comparing combination immunotherapy to monotherapies. And you can see here that actually we've done a lot of good, and the median survival now is greater than 3 years. However, it is still clear to know that most patients will develop resistance and most of our patients will still die. So although we've made an incredible amount of progress, I think there's still a lot of work to be done. And for those of us who work in the laboratory, this is of incredible interest. And the patterns of response with these immunotherapies are somewhat different to what we see with molecularly targeted therapies. And the reason for this is that, the way these therapies work is that the tumor cell produces antigens that are not recognized as self, so neoantigens, and they're presented through antigen-presenting cells, and then they activate T cells and hopefully can stimulate T cell responses against a tumor. I put the yin and yang here because this is a very dynamic process, and there's many ways that this can be pushed to the favorable or less favorable direction. And so what my lab does, in addition to my clinical practice, treating melanoma patients with surgery, I run an immuno-oncology lab, and we take patient tumors and patient blood, and we want to ask clinical questions about why some patients do better, so why some patients do worse, can we detect tumor in the blood, and ideally, how can we feed this back to improvements in clinical care? That's the gist. And I think that we will say that this dynamic process is ongoing, and we actually have learned a lot already, and this is in the relatively short period of time that we've been using these drugs clinically. And so I'm going to touch briefly, I'll try to focus on the parts of relevance to this crowd, but we have taken different approaches to doing this. Some are studying melanoma cohorts, groups of patients. Some are studying 1 or 2 patients individually, but in a very deep manner. And that's where we've used a lot of this multiplex imaging. And then we've transitioned some of our work from tumors to the blood, which would be a more clinically actionable strategy. And so this was some of the early work done by our group at MGH in conjunction with Nir Hacohen, where we sequenced tumors. This is whole exome sequencing of tumors longitudinally in patients being treated with immune checkpoint inhibitors. And basically what we were able to find was that the acquisition of mutations in beta 2 microglobulin, or MHC class 1 presentation, were acquired during treatment with melanoma immunotherapy as the patient became resistant. And that loss of beta 2 microglobulin or loss of heterozygosity was associated with increased risk of resistance to immunotherapy. A follow-up paper we did again with Nir and Moshe from his group used single-cell RNA sequencing to look at tumor-infiltrating lymphocytes. And here we were able to identify good and bad clusters of T cells, and the ratio of good to bad per lesion was predictive of response to therapy. And by using multiplex imaging, we identified these these immune cell populations via single-cell RNA-seq, but then we could apply immunofluorescent panels to look at the T cell infiltrate in a given tumor with the idea that we could use this to predict which patients would respond. So the good cluster with TCF7, were our T cells infiltrating into the tumor high in TCF7 versus the bad cluster, CD39 or TIM3. And we actually have been feeding this back and creating a CLIA panel within our institution. This is efforts driven by John Chen, one of our pathologists, to try to use this on a tissue type basis to hopefully guide clinical management and clinical care. So what have we done since then, and how do these mechanisms interact within individual patients? And one of the observations I made in my clinical practice was that in patients who were resistant to immunotherapy, so when I would resect tumors in patients who were progressing on immunotherapy, they looked a lot more like the treatment on the left rather than the right. And the right is what melanoma looks like to most of us grossly. It's pigmented and dark. And the enrichment of these non-pigmented tumors made us ask the question, well, are we selecting for a dedifferentiated or less melanocytic lineage? And there was some suggestion in the literature that this occurred in the setting of targeted therapy resistance, and that this more neural crest, less differentiated phenotype of tumors was potentially more aggressive. And so we wanted to pursue this further. We worked with Daniel Pieper's group in the Netherlands, and they had a model where they could treat tumor cells ex vivo with T cells, and they saw that the resistant group was higher in this neural crest type program. When we looked at our patient samples, we could see both in immunotherapy and targeted therapy resistance and enrichment of this NGFR high, potentially neural crest-like cell state. Those seem to be associated with immunotherapy resistance. We also worked with David Fisher, similarly looking at cross-reactivity to lineage-specific melanocytic antigens, meaning if neoantigens drive the immunotherapy response, do other antigens sustain it, such as lineage-specific antigens? And we actually used T cell populations in circulation, and we could identify T cell populations specifically recognizing melanocytic antigens, and we were able to show that the persistence of these T cells recognizing melanocyte-specific antigens correlated with a more durable response to therapy. So we could not only use different tools to identify T cell populations and look at what antigens they may be recognizing, but then we could track these T cell populations in circulation, hopefully to create better biomarkers of both responses and potentially durable responses. And then another study we've done, and this was Dave Liu at the Dana-Farber and Peter Sorger at Harvard Medical School, was to look at one of my patients longitudinally over time. And this is a patient who we were able to follow across the course of 9 years. And we were able to track changes both genetically via whole exome sequencing to look and infer immune cell populations via single-cell RNA sequencing, and then really to confirm the spatial interactions of these immune cell populations via CISIF or multiplex immunofluorescence with Peter Sorger. And we found from a genetic standpoint that actually there was a lot of genetic heterogeneity in the patient's beginning of his treatment when he was rapidly progressing prior to initiating this immunotherapy clinical trial. And that basically over time, he began to have a response, and many of these genetic clones or lineages were pruned from the tree, and what persisted or grew out and was actually present in all of the rapid autopsies when he subsequently or eventually succumbed to his disease, that was from one lineage. And fortunately or unfortunately, this lineage had acquired mutations associated with known resistance-associated alterations, loss of beta-2 microglobulin, genome doubling, CDKN2A mutation. But interestingly, the loss of beta-2M was insufficient by itself. The patient was still responding at this time, but the selected lineage that eventually grew out was multi-drug resistant through a variety of distinct pathways. And what we could do with the imaging of this patient's tumor was look at specific T cell subsets. So I said we'd already been, tumor cell subsets. We were already interested in this NGFR high, more dedifferentiated cell population versus the MITF high or more differentiated population. And what we saw with imaging was that the cytoarchitectural patterns of this NGFR high group of cells was very distinct to that of the MITF high or the normal melanocytic lineages. So you can see here it had a vasculogenic mimicry phenotype. So this was the creation of non-endothelial lined vessels by this tumor phenotype. And this has been associated with a dedifferentiated aggressive melanoma phenotype. What we could do with the multiplex imaging, since it was all done on the same slide, was this sort of spatial and machine learning approaches, and we could identify clusters of both tumor cells, so looking at our NGFR versus MITF, gating on S100, which is a tumor cell marker, or looking at immune cell populations via CD45. And interestingly, when we did specific analysis comparing these two tumor cell populations, we saw that our NGFR high tumor cells had higher levels of PD-L1 as compared to the other tumor types. And when we did spatial analysis or neighborhood analysis, looking at the relationship of MITF high tumor cells to immune cells versus the NGFR high tumor cells to immune cells, we found that the NGFR high tumor cells were in closer proximity to immune cells. And as I mentioned, they were also PD-L1 high, suggesting they may play an immunomodulatory role. When we had paired biopsies, the same biopsy sampled twice, we were pre and post treatment, and this was with a TLR9 intralesional agonist plus PD-1, but this was a non-responsive tumor. We saw that there was a huge selection for this NGFR high subset, and despite increase in immune cell infiltrate, we know that the tumor eventually progressed on therapy. We had single cell RNA-seq, and we were able to look at the NGFR high versus non-NGFR high tumor cells. And doing GSEA, we could see that the NGFR high tumor cells were enriched in hypoxia, TGF-beta signaling, and had this EMT-like or more dedifferentiated phenotype. So we had now integrated bulk sequencing, multiplex imaging, and single cell RNA-seq. And because we were able to follow this patient over time, and unfortunately for him, we were able to sample his tumors after his death via rapid autopsy, we were able to look across anatomic sites to see if these patterns were consistent or specific to different anatomic sites. And although the number or proportion of NGFR high tumor cells within the tumors in different sites were quite similar, the tumor cells in the lung sites as compared to subcutaneous were more proliferative. The immune cell populations were quite similar, but if you look down at these representative images, the distribution of the tumor cells within the tumors was quite distinct. In the subcutaneous tissue, it was more in a polar or at the periphery, and the lung was more distributed. And this was just representative H&Es and these scores of polarity versus entropy, suggesting that this potentially immunomodulatory tumor cell population might be playing distinct roles in different anatomic sites. And so finally, how can we take what we've already begun to learn from the tumors and start to think of more easily or clinically actionable ways of assessing these same changes? I mentioned before that we had looked at circulating T cell subsets to see if lineage-specific T cells were a useful biomarker. But we've also sort of cast the net more broadly. And I would argue that when one's thinking about immunotherapy, as opposed to targeted therapy or other approaches, when we think of blood-based biomarkers, we need to think beyond the tumor and just tumor intrinsic benchmarking, which I think is what we get with CTCs or circulating tumor DNA, where you can benchmark the persistence of certain tumor cells or tumor populations. In immunotherapy, particularly to predict or monitor responses, we really need a tool or multiple tools that can assess both tumor intrinsic changes, tumor burden, tumor persistence, as well as changes in the immune microenvironment. And that will really be instructive for us in this particular context. And so we undertook a bulk EV or actually a vesicle analysis of plasma derived from immunotherapy patients, asking the question that without selecting for tumor specific EVs, but rather just looking in plasma in general, could we monitor both tumor and or potentially immune related changes in these immunotherapy patients? And we used two distinct cohorts to do this whole transcriptomic analysis from extracellular vesicles, but we did see differences in our responders and non-responders, both at pre-treatment and on-treatment time points. And we actually saw that the mutational load as assessed in these extracellular vesicles actually correlated with response to therapy. But we were able to have paired tumors in some of these patients. And we wanted to see how similar were the signals we were getting in the peripheral blood via EV transcriptomics to the patient's bulk tumor. And we actually saw a high degree of concordance. And then we were interested in what transcripts we might be getting from extracellular vesicles that we were not getting from the tumor. And some of them seem to be coming from immune cells. And we created a deconvolution model based upon a variety of inputs, including normal patients and cell culture and cell culture-based EVs, to come up with a Bayesian probabilistic prediction model of are the transcripts we're identifying in circulation coming from tumor or non-tumor sources. So we first did a sanity check of transcripts we knew the source for, and then we looked at our differentially expressed genes, and many of them seem to be arising from tumor sources. But interestingly, over time, the differentially expressed genes that were important in predicting or distinguishing responders from non-responders seem to be coming from other sources, meaning non-tumor sources, suggesting that as the immune system was ramping up, we might be getting a better readout of these immunologic changes over time. And then we use some existing deconvolution approaches to try to predict which immune cell populations might be contributing to these signals, for the idea of potentially enriching for these signals down the road. And actually, that's what we're doing now with Chan and Stott at the MGH. We're using a microfluidics chip to actually extract EV populations from specific cells of interest in parallel, with the idea that hopefully we can refine the signals that we're getting from the bulk analysis and really improve our signal to noise ratio. And finally, we're working with Nir Hacohen again and Arnav Mehta, one of our medical oncology fellows, and Olink to look at plasma proteomics. Can we look, and we have both a exploratory and a validating cohort where we've identified proteins in circulation, this is just bulk plasma proteomics, that correlate with response to therapy, and that we've been able to use our existing single-cell RNA-seq data sets to try to deconvolve or predict which immune cell subtypes may be contributing these proteins that are able to discriminate responders from non-responders. And interestingly, we identified the source of many of these as monocytes in the tumor microenvironment, and this work is almost ready for submission. So overall, I think that this has been sort of a whirlwind run through changes in immuno-oncology and melanoma, but we really have begun to understand via tumoral analysis these tumor intrinsic and immune-related programs that are associated with immunotherapy non-responsiveness. We've been using both single-cell RNA-seq techniques as well as now single-cell resolution imaging that really help us to not only define which cell populations are there, but actually to look at their spatial interactions. And this becomes critically important as we try to characterize tumor phenotypes or subgroups of tumor cells with different immune cells in circulation. So we've been ramping this up. Unfortunately for us in the clinical world, it's unfortunate to know that probably patients will have multiple resistance-associated alterations, meaning we need to think about a therapeutically multi-pronged approach. It's not going to be one size fits all, or maybe even one drug for one person. That blood-based tumor and immune monitoring is feasible, and I think this will be an expansion area in the future and something we're certainly interested in pursuing. So I thank you for your time and obviously for our funding sources, but the most important gratitude really should go to our patients who contribute their time, their resources, and their personal experiences so we can understand this disease better. Thank you so much.